Welcome, everybody, to today's webinar. My name is David Ahrens, and I am the CEO of National Brain Tumor Society. Hope everybody's doing very well. Thank you so much for joining today. On behalf of the Jumpstarting Brain Tumor Drug Development Coalition, including Accelerate Brain Cancer Cure, the Musella Foundation for Brain Tumor Research and Patient Information, the Society for Neuro-Oncology, and National Brain Tumor Society, we are grateful that you are joining us today to learn more about the standardized brain tumor MRI imaging protocol for clinical trials. This webinar is brought to you by the Jumpstarting Brain Tumor Drug Development Coalition, a group that was formed in 2013 with the purpose of improving brain tumor clinical trial endpoints, including those focused on imaging as well as clinical outcomes, as a means of accelerating and improving the development of new and effective treatments for brain tumor patients. In today's webinar, consensus recommendations for a standardized brain tumor MR imaging protocol will be presented, along with the scientific and practical justifications for these recommendations. The imaging protocol that will be described and discussed is the product of months of work by the members of the Coalition's Brain Tumor Imaging Standardization Steering Committee, made up of an international group of experts ranging from neuro-oncology, neuroradiology, neurosurgery, patients, the government, regulators, funders of research, a whole wide range of stakeholders are a part of the steering committee. This committee is chaired by Dr. Mark Gilbert, who is the branch chief of neuro-oncology at the National Cancer Institute, part of the National Institutes of Health. Today's webinar includes some of the foremost experts in the field of neuroimaging. They include Dr. Dan Barboriak from Duke University and a leader in the Akron Clinical Trials Cooperative Group, Dr. Martin Benzus, neuroradiologist from the University of Heidelberg in Germany and a leader in the EOR-TC's imaging area, Dr. Ben Ellingson of UCLA and a principal author of the MR protocol with the steering committee, Dr. Patrick Wen of Dana-Farber and the chair of the overall Brain Tumor Endpoints Initiative. This webinar is intended to be interactive, and there will be an opportunity to ask questions, and we hope you do ask questions. Please submit your questions through the Q&A pod feature on your screen. This webinar will be recorded and made available on the National Brain Tumor Society and ultimately a website for the coalition at a future date. Now I would like to welcome Dr. Patrick Wen to provide an introduction of today's topic and a background, and to welcome the other presenters. Thank you, Dr. Wen.
Thank you, David. I want to thank David Ahrens and Kingston and the Jumpstarting Brain Tumor Drug Development Coalition for organizing this webinar and for all the hard work they've put in over the past year to make this a reality. In 2014, the Jumpstarting Brain Tumor Drug Development Coalition, together with the FDA, conducted 2 workshops looking at endpoints in clinical trials in neuro-oncology with the hope of accelerating development of better therapies for our patients. The first workshop that took place in January of 2014 focused on neuroimaging endpoints. The summary of this workshop has been published in Neuro-Oncology and is available online for all those who are interested. One of the major outcomes of this workshop was the need for standardization of neuroimaging in neuro-oncology. Currently, there is significant variability in the way imaging is performed, and this reduces the reliability of imaging data required for determination of endpoints for clinical trials. And so there was general consensus from FDA, from the participants from NCI, from the neuro-oncology community and imaging groups, that standardization of imaging in neuro-oncology would be a step forwards. There has been experience with this in other diseases. As many of you are aware, the Alzheimer ADNI initiative has been a major area of progress in that disease. And so we came out of the workshop with the plan to develop standardized imaging in neuro-oncology. Over the past year and a half, led by Ben Ellingson, Martin Bensis, Dan Boboriak, and Mark Gilbert, and many others, as David mentioned, we've developed a standardized imaging protocol that has been published now in neuro-oncology over the past month. And again, it's available for everyone to access online, together with an editorial from the FDA from Juhi Sul and Dan Kraniak supporting this initiative. This has been a really important step forwards in our field, and these imaging parameters have now been adopted in Europe by the EORTC, led by Martin Bensis, and in North America by a number of cooperative groups, including the Alliance Cooperative Group, the Adult Brain Tumor Consortium, the Ivy Consortium for Early Phase Clinical Trials in Glioblastoma. And there are efforts underway for international trials to use these imaging parameters also in China and Australia and other countries. So thank you for joining this webinar. I know you're all very busy, and we're very grateful that you're participating in this effort, and hopefully together we can develop better treatments for our patients, something that's desperately needed. So I'm going to now introduce you to Ben Ellingson, who led the standardization effort and is the lead author in the imaging protocol that's published in Neuro-Oncology this month. Ben is an associate professor of radiology at UCLA and a head of the brain tumor imaging lab at UCLA. So Ben, please go ahead.
Thank you, Patrick, and thank you everybody for attending. So now I'm going to talk and step through the standardized brain tumor MRI protocol recommendations for the use in clinical trials, and also step through the scientific and practical justifications for the choices we made in these particular protocols. So as was mentioned before, this stemmed from an FDA meeting in early January 2014 that highlighted the need to standardize MRI acquisition protocols for the use in clinical trials. So the FDA suggested that we needed to come up with a standardized MRI protocol in order to increase the confidence in using imaging response as a surrogate for drug efficacy in brain tumors. And as has been mentioned before, and as most people are likely aware, most clinical MRI sequences tend to be T1 or T2 weighted, which means that lesion contrast is really highly dependent on the sequence parameters that are chosen for the particular acquisition. And so as a consequence, lesion size is subjective due to the ability for the reader or the algorithm or the computer algorithm to really generalize across the levels, the various levels of image quality. We also have an ethical reason for requiring a standardized protocol, in that this now allows us to perform comparisons in pooling data across different studies and different drugs. And so this is ethically important in order to limit the number of patients on ineffective drugs and to potentially pool subjects across various trials in order to use population data as a benchmark. And so just to step through some reasons why we need image standardization. And the first reason is really to reduce measurement variability due to differences in protocols. So as I mentioned before, minor differences in hardware or sequence timing, for example, echo time or repetition time, can result in significant changes in the resulting image contrast. So here we showed two examples of the same patient that were acquired using two different acquisition strategies, one being a 2D fast spin echo, post-contrast T1 weighted image, and the other being a 3D inversion recovery prepared gradient echo. And you can see that the bidimensional measurements between these two acquisitions that were acquired right after each other are different. And so this just highlights the need for us to reduce this measurement variability by standardizing the acquisition. The second reason is to reduce any variability that might be due to the contrast timing. So studies have shown that the time between the injection of contrast and acquisition of the post-contrast T1 weighted images really affects the amount of contrast enhancement that we see in the images. And studies have suggested that contrast agent type, dose, and timing are critical for evaluating the amount of contrast enhancement. And it's been suggested that anywhere between 4 and 8 minutes after contrast administration is really optimal to see sort of the largest extent of the lesion that's malignant. Another reason for performing image standardization in clinical trials is the use of automated volume segmentation and potentially feature extraction. So studies have shown that there is difficulty in defining the exact margins and really identifying the largest diameter or perpendicular diameter when looking at different types of tumors. So as you can see in this example below, because of the difficulty and the irregular shape in the enhancement pattern, 2 different radiologists might get dramatically different measurements of tumor size based only on perpendicular or largest diameter measurements. So subsequent studies have shown really low reproducibility in 1-dimensional and 2-dimensional measurements of brain tumors, and that this reproducibility can be increased if we use volume measurements of the tumor. And so we can really reduce the coefficient of variance across different readers and across the same patient over time by performing volumetric measurements. And so it became obvious to us that there are a wide variety of imaging capabilities that are in use for large clinical trials, anywhere from small outpatient clinics and imaging centers, which really have minimal imaging capabilities and technical capabilities, through community medical centers that may have basic capabilities, all the way to academic medical centers that may have advanced capabilities as well as advanced technologies and expertise available. And so it became apparent that we may need different yet synergistic imaging protocols in order to accommodate and be able to pool and combine data from all these different types of medical centers. And so first is really a minimum standardized MRI protocol. This is really designed for the small outpatient clinics and community imaging facilities in which we're really concerned about large throughput, fast protocol, minimum chance for error, and looking at acquisition times on the order of about a half an hour in order to really make clinical decisions a priority. Next is really a basic standardized MRI protocol that's really designed to work for most community medical centers and really most sites that might be part of large cooperative groups as part of clinical trials. So this again is really focused on a standard clinical throughput, and the typical protocol would last around 30 minutes. We also wanted to be mindful with regards to sort of advanced or optional modules for advanced imaging that we may want to integrate into the protocol for depending on the needs of the trial. So we wanted to design our standardized protocol for academic medical centers in mind with experience in advanced imaging and allow them the flexibility to add these additional modules, but still retain the ability to combine the data and pool the data across the trials in the end. So this, our consensus recommendations were published recently in this September issue of Neuro-Oncology, and this really represents a wide range of expertise from neuro-oncology through neuroimaging, through neurosurgery, representatives from a variety of cooperative groups as well as societies were represented. And again, the details were published in Neuro-Oncology earlier this month. So in designing the standardized MRI protocol for use in therapeutic trials, we really designed it to be in line with the EORTC, ACRIN, the Alliance, and the ABTC protocols that either currently exist or have been used in the past. And we really wanted to focus on making this work with almost all community medical centers and most of the sites that would be involved in these large cooperative groups and use in large clinical trials. It was designed for a standard throughput and is designed similar to the basic EORTC protocol, specifically around a 1 hour setup to takedown or about 30 minutes of actual image acquisition. Little technical expertise necessary in terms of setting the patient up, and no special equipment, including power injectors, are absolutely required. So in designing this protocol, we we had to deal with a philosophical debate or a philosophical dilemma in regards to trying to maximize compliance such that we can allow a lot of the sites that are part of these large consortiums to acquire imaging data as part of the trial, but also to maximize data quality such that we're able to acquire data that's comparable and of high image quality so we can pool it across the various trials and the various centers. And so it became apparent at first by trying to just maximize data quality and really become rigid in terms of the acquisition parameters, we tended to exclude a large number of the small imaging centers that may not be able to live up to these standards. So we really designed the current protocol in order to create a balance between maximizing compliance and allowing most of the sites to be able to do this and maximizing data quality where we're able to obtain high quality image data. So these are the recommended minimum standard 1.5 and 3T MRI protocol sequence parameters. And again, the sequence details are published in Neuro-Oncology in September. So I'm not going to go through a lot of the details on the actual sequence parameters, but I do want to step through some specific sequences and provide some justifications for our current recommendations. I do want to point out again that this is designed for clinical trials only, so we are not intending to remove the current routine clinical standard of care imaging. However, we did design this with in mind such that it can be used for routine clinical care, but is specifically designed for to ensure consistency in brain tumor clinical trials. So there are some current misconceptions with regards to this protocol with respect to the ability to add additional sequences to this protocol during clinical trials if the clinical sites think that it's appropriate. So we do want to point out that additional sequences can be and should be added so long as the minimum sequences are acquired. So for example, some sites have suggested that their radiologists might require additional 2D T1 weighted post-contrast triple spin echo scans, and so these can be acquired after the acquisition of the 3D T1 weighted post-contrast scans in order to accommodate the individual site needs. Similarly, T2 star weighted gradient echo scans to look for bleeds, for example, are not necessarily required as part of this protocol because they're not required for RANO reads and for response assessment, but can be added per the local needs of the individual site without any sort of penalty, and it's actually encouraged. So the first and probably most important portion of the minimum standard MRI protocol is the acquisition of pre and post contrast parameter matched 3D inversion recovery prepared T1 weighted gradient echo images. And so these, also known as MP-RAGE or SPGR images, are available from all the three major MRI vendors as part of the ADNI or Alzheimer's Disease Neuroimaging Initiative standardization effort. So these are already readily available on most scanners. We require or recommend that images be acquired between 1 and 1.5 millimeter isotropic resolution. Again, the 1.5 millimeter isotropic are really designed to accommodate some of the lower field and older scanners. We really want to focus more on the 1 millimeter isotropic resolution. By acquiring it in 3D, we can reformat these to 3 millimeter slice thicknesses, for example, in 3 different planes. So in the axial, sagittal, or coronal planes, using the same data set. The use of 3D gradient echo is used routinely for both pre-surgical planning as well as radiation therapy planning. So this is a sequence that's widely used in the clinic currently and used in neuro-oncology specifically. This sequence is RANO compliant, meaning that the bidirectional measurements and all of the RANO requirements for contrast enhancing tumor burden and tumor assessments can be done off of these 3D T1 weighted images. The acquisition of the 3D images over time in the same patient will allow us for longitudinal registration of this data over time. So this can be used to align the brain images in the same patient in order to better match slice prescription and brain tilt, so the measurements are not as biased and can be changed based on head tilt. The acquisition of parameter matched pre and post contrast T1 weighted images also allows for us to use T1 subtraction, which is a relatively older technique that can be used to highlight the areas of subtle contrast enhancement that we sometimes see in various circumstances. So just to briefly step through the advantages of T1 subtraction. So this technique is not a new technique. It's been around for 20 to 30 years. It's recommended by the American College of Radiology in order to increase lesion conspicuity and to subtract out the blood products from post-contrast T1 weighted images. So the method is such that you subtract the pre-contrast T1 weighted images from the post-contrast T1 weighted images, resulting in subtraction maps that highlight the areas that have actually enhanced due to the administration of contrast. So in the past, this has been primarily used to look at areas of residual tumor-related enhancement and subtract out areas of blood products. But we and others have shown that this is beneficial also in the setting of anti-angiogenic therapy, where you may get what looks like normalization of contrast enhancement, but subsequently on T1 subtraction images, we actually see contrast enhancement in these areas that had subtle enhancement. So these are just some examples from a phase 2 trial looking at bevacizumab, as well as a phase 3 upfront trial, just demonstrating the ability for T1 subtraction to better demarcate the enhancing lesion extent. We also have evidence that this might be beneficial in looking at contrast enhancing lesion volume or lesion size over time with new types of immunotherapy as well. So why are we interested in using 3D inversion recovery, GRE, and not three-dimensional turbospin echo or something else? So the primary reason is because this has already been standardized as part of the ADNI effort. So the major MRI vendors have already come together and already distribute these sequences as standard products in their new scanners. So they have already been vetted in terms of their ability to be comparable. ADNI spent more than $60 million in more than 10 years of development in order to come to this standardized ADNI protocol, which involves the 3D inversion recovery GRE. So we don't want to reinvent this effort. They went through a lot of resources and a lot of time in order to develop and come to a consensus on this protocol. And the accuracy is really well documented. So in the Alzheimer's disease literature, for example, this type of sequence can detect changes in hippocampal volume of around 5%, which is quite high accuracy and really speaks to what we might be able to do in brain tumors if we were able to standardize this. So the inversion recovery GRE, or the MP-RAGE sequence, is most commonly used sequence for fast 3D T1 weighted imaging of the brain in general. As I mentioned before, it's routinely used for surgical and radiation therapy planning in brain tumors in most institutions. So it's already being acquired as part of brain tumor protocols at local sites. It really has been used for more than 20 years in brain tumors. So there really is a wide body of literature supporting the use in brain tumors and its ability to actually highlight the microvasculature. It allows for significant enhancement of vascular structures, including the large feeding vessels. So although some investigators have suggested this may reduce lesion conspicuity, this may help us to highlight areas of co-opting vessels and large vascular structures that are actually feeding into the tumor. So there may be some trade-offs associated with it. So this particular sequence that we're choosing, the 3D inversion recovery GRE, is in agreement with previous ACRIN Alliance and EORTC imaging guidelines. So this is in line with requirements that have been recommended for clinical trials and cooperative groups. We are allowing the use of motion insensitive versions of this sequence. So for example, Vibe or Bravo allow you to reduce the amount of motion artifact that's present in these types of sequences. Additionally, 3D turbospin echo sequences are not really standardized across vendors. So although some sites may be having really good results with that, a GE versus a Siemens, a version of the 3D turbospin echo, or are not the same. So cube sequence, for example, is not really acquired in the same way that a space sequence is acquired. It tends to be very sensitive to motion. It's not available on all systems, so most of the older systems do not have this sequence available. And even on newer sequences, this may not be available, or even on newer systems, this may not be available without additional money, so without paying for this additional package. And lastly, we want this current protocol to really serve as a much needed benchmark for really testing new sequences. So if for example, 3D turbospin echo ends up being quote unquote better sequence, then we want to at least say it's better than the current protocol or the current benchmark, which is the 3D inversion recovery gradient echo. Another thing to point out is the acquisition. So another part of the protocol is the acquisition of 2D T2 weighted turbospin echo, although we're really recommending the acquisition of a dual echo proton density T2 weighted turbospin echo. This type of sequence is RANO compliant and is routinely used by most centers, at least in the single echo sense. The dual echo is available on all scanners as part of the ADNI initiative. So they had looked at dual echo acquisition as part of the ADNI protocol. Dual echo acquisition and T2 quantification actually is part of the American College of Radiology scanner accreditation process. So most of the clinical scanners that are going to get Medicare reimbursement and other types of insurance reimbursement do require some sort of accreditation for which dual echo is recommended. And as I mentioned before, this if we acquire dual echo, it may allow us for quantification of T2 within clinically feasible scan time, such that we can start to create an objective criteria for defining non-enhancing tumor and reduce some of the controversies that are surrounding T2 or flare progression, for example. So just to provide a couple of examples of why this might be interesting or important. So we and others have shown that specific types of tissues have specific T2 characteristics, and these can be defined and quantified using dual echo turbospin echo. And so using a range of T2 measured values, we may be able to objectively define some corridors for what we might call non-enhancing tumor and be able to monitor that over time. And this is just an example of how you can acquire multiple echoes or dual echo acquisitions at various field strength and various scanners and create comparable T2 maps from these different types of image quality. The next thing to point out in terms of the protocol is the timing of the contrast and more specifically the timing of the contrast injection with respect to the T1 weighted post-contrast T1 weighted images. And so what we're recommending is that you insert the axial 2D T2 weighted images right after contrast injection in order to serve as a buffer between contrast injection and the 3D T1 weighted post-contrast images. So as I mentioned before, the timing between the injection and the post-contrast images is really critical to ensure that we get enough or a standard amount of contrast extravasation into the extravascular space. And the insertion of the 2D T2 weighted turbospin echo is less sensitive to contrast being on board because it is a spin echo technique. You're going to see less issues associated with contrast being on board with this sequence if you insert it post-contrast. Additionally, we're asking that you acquire T2 weighted flare, again with the turbospin echo acquisition. This is the basic fluid suppression technique that's used pretty routinely at most clinical sites now. It's used for RANO evaluations, specifically looking for unequivocal non-enhancing tumor progression. It's similar in the acquisition parameters to the ACRIN, EORTC, and Alliance protocols. And the acquisition of 3D flare is optional, and we provide some recommendations for acquisition of 3D flare if your site wants to use 3D flare. These are just some examples stepping through that we're able to acquire 3 millimeter slice thickness with no gap, even on older lower quality machines and machines with lower field strength. So these are the same patients acquired at different times on a GE 1.5T scanner, a Siemens 1.5T, and a Siemens 3T scanner. And it's important to point out here that they have comparable image quality between the three different types of scanners and the two different techniques. This is just another example of another patient similarly acquired on a GE 1.5T, Siemens 1.5T, and then a Siemens 3T, again showing comparable image quality even at 3 millimeter slice thickness. And so there was some questions regarding our recommendations to have a minimum of 4 millimeter slice thickness, and this just demonstrates that even at 3 millimeters we can get adequate image quality across these different types of scanners and different levels of scanner quality. We also are recommending collection of diffusion-weighted imaging using the recommendations from the ISMRM NCI diffusion consensus meeting in 2008. So namely, the acquisition of 3 V values is recommended. So 0, 500, and 1,000 are the V values that are recommended in order to quantify the apparent diffusion coefficient accurately. So there are some additional information and subtext and footnotes that are available in the actual manuscript. I'm not going to cover them all, but I do want to cover a couple of things that are worth mentioning. So first, we do allow for radial acquisitions if there is significant patient motion. So specifically in the diffusion sequences, we allow the use of blade, propeller, or some of these other radial techniques in order to reduce the amount of image distortion or motion artifact that may be present. As I mentioned before, we do advocate the use of advanced sequences, and these can be substituted into various time slots so long as the critical anatomic images that we're trying to standardize are really collected and collected in similar times post-injection. So we're not trying to hinder advancements in some of these new types of image acquisitions, but we do want to keep coherence among the core anatomic images. As I mentioned before, the use of 3D FLAIR is an optional alternative to 2D FLAIR, and we do have some recommendations per the EURTC guidelines for how to adequately acquire 3D FLAIR images for 3T scanners and 1.5T scanners. And lastly, we do allow for grandfathering in of old scanners, and we are aware that some of the old MR scanners are not able to acquire more than 2 V values. So in this case, we are asking for a minimum of at least V0 and V1000 images for the diffusion-weighted images, diffusion-weighted imaging acquisition for this protocol. So this is an example of our recommended 3T protocol for clinical trials. So again, this is published within the Neuro-Oncology article, but I do want to point out specifically the acquisition of 1 millimeter isotropic resolution 3D T1 weighted pre and post contrast images, as well as 3 millimeter slice thickness axial acquisitions for 2D FLAIR, diffusion, and T2 weighted images with no interslice gap. For the recommended 1.5T protocol, you'll notice that most of these recommendations are actually very similar to the minimum requirements for the protocol, namely that the 3D pre and post images are acquired with less than 1.5 millimeter isotropic resolution compared with the 1 millimeter that we're asking for 3T. And then the slice thickness for FLAIR, diffusion, and T2 weighted images being less than or equal to 4 millimeter slice thickness, again with no interslice gap. So now I'm going to step through a few examples of compatible protocols in which you may add site-specific sequences to the standardized protocol and still be compliant with the recommendations. So this first protocol is an example of how you can acquire axial 2D T1 weighted turbospin echo images that may be required by your local radiologist or your local site. So here we have it after the acquisition of 3D T1 weighted post-contrast images in order to highlight or subsequently have another measurement of the amount of contrast available. If your site performs dynamic contrast enhanced MRI or DCE MRI, we recommend that you put it into the sequence prior to the 3D T1 weighted post-contrast images, and you actually take out the axial 2D T2 weighted images. So you would acquire your T1 map pre-contrast, and then start your dynamic scan with the injection of contrast. Then following that dynamic scan, then acquire your 3D T1 weighted post-contrast images. This is an example of how you might substitute diffusion tensor imaging, or DTI, in for the diffusion weighted imaging. And we are going to have some specific requirements, or some specific recommendations rather, for diffusion and perfusion at some subsequent time points. But for now, you can see how you can substitute DTI for the DWI protocol. And then if you're using DSC perfusion, or dynamic susceptibility contrast perfusion, you would inject your preload contrast, acquire your dual echo proton density, or T2, or just your T2 weighted image, to allow for the preload to extravasate, and then inject your contrast agent bolus, acquire your dynamic susceptibility contrast perfusion images, and then subsequently collect your 3D T1 weighted post-contrast images. So we do have examples of various protocols available currently on my website here at the top, but soon will be likely ported over to an NVTS website or a different website. So on here we have a version of the recommended protocols, the white paper. We also have Siemens downloadable protocols that you're able to upload directly into your scanner, as well as downloadable protocols from GE for a few different types of scanners. So we do encourage various sites, if you're developing compliant protocols with the standardization recommendations, that you submit or send us your protocols so we can upload them to the website and have them available to other sites that may want to come into compliance. So with that, I want to thank you for your attention and answer any questions that you may have about the protocol or scientific or practical justifications for the specific parameters that we chose to use. Thank you.
Asked a great question asked by Jennifer Buell. Is an imaging limitation we have faced with radiologic outcomes is the differentiation of pseudoprogression versus progression in brain tumor trials. And we endeavor to support the enhancement of accuracy of progression endpoints and potential to advance more timely therapies to patients. So will this imaging standardization support that kind of effort? And welcome Dr. Benzus to answer that question.
I guess the biggest problem with pseudoprogression is that we don't have good data on that. I mean, there are very different reports on the frequency of pseudoprogression, and the cause for this is that imaging data were not very robust. And I guess we have a very good chance with standardized MRI data now in trials to have a good idea on the frequency and the relevance of pseudoprogression. So I think it's a very important step to have more understanding of pseudoprogression. And the second thing is that we also work on standardization of advanced MR techniques like MR perfusion or diffusion, and they contribute more to the understanding of pseudoprogression. And I guess this will be a second step for a better management of pseudoprogression by imaging.
The next question that came up, thank you, Dr. Benzus, still related to this subject, is what are the concerns with switching from 3T to 1.5T on study if this issue arises? And invite any panelists to answer that question.
Yeah, we discussed that a lot within the group, and I guess apart from the adherence to the MR protocol, adherence to the field strength is crucial. And it's a very bad idea to change field strength within a patient. So if you have the same patient, please always apply the same protocol at the same field strength. That's very important. Otherwise, you will have a big problem to interpret the data.
Thank you, Dr. Benzus. Another question that's come up is are there data to show that the use of the standardized protocol has started to reduce variability in data aggregation across sites? Ben?
Well, so only recently have studies started to comply with the protocol, and so we do have a couple of studies that are now starting to ramp up, and we have good adherence to the protocol. but I can speak to the fact that at UCLA, all of our 22 scanners currently on site are using the standardized protocol. And we are getting consistency across the different scanners on the different patients. So we don't have data yet to show that it's reduced variability, but this initiative has just started. So we think that data will be coming in shortly.
We have been using this protocol for years now in Heidelberg and have applied this protocol within ERTC study where we do also quality control. So it's very timely, and we just experienced no problems over many hundreds of MR examinations with adherence to the protocol and also in quality control. So it's really, I guess, very practical and works in routine in Europe. And I guess that should be the case in the US as well.
Thank you. Another question that has come up is the intent to use this protocol for routine clinical care?
That's not the intent, if I can answer that. This is really, as Ben mentioned, designed as a clinical trials protocol. I think one of the things that's really great about the protocol is that it is usable as part of a clinical acquisition, and how you adopt that to your individual site will depend a little bit upon your local needs and in a sense your clients who are looking at the images. So it's a great start for a clinical protocol as well. But the purpose of this was really for trials.
Thank you, Dr. Barboriak. Another question that's come up is, through standardization, are we going to be limiting our ability to innovate and derive better protocols? I think Ben has described that we want more protocols, but Ben, if you could say a bit more about how this protocol relates to innovation.
Right. So I've been careful to try to say that we're not trying to limit innovation. So what we want to do here is really standardize it such that images can be combined across various trials. So we do recognize that there may be better or worse sequences out there, but we really wanted to kind of balance the needs of the trial and the needs of the community here. That being said, it's difficult when one particular site tends to say we have a quote-unquote better imaging protocol than what you're recommending in a clinical trial, because in essence, that's relatively subjective. And secondly, if their site's doing something completely different than all the other sites, the usability of that particular site's data in the community or in the data pool at large really becomes minimal, and it's as good as if it's not, or it can be treated as if it's worse data. So I think what we're trying to do here is really for clinical trial purposes. We're not trying to hinder any innovation. Welcome it, but I think we need a benchmark to say, okay, this is the standard. Now, if you have a better technique, show us how and why it's better compared to that benchmark. So I think it can set the stage for more innovation. I think if we can agree that this is a starting point.
Thank you, Dr. Ellenson. Are there any other comments on that subject or comments that any of the panelists would like to make, Dr. Benzus, Dr. Barboriak, on that concept of innovation?
I would agree with Ben completely. The innovation is a little bit in the eyes of the beholder, has been implied. The issue with it, I think that what's nice about this protocol is that if you have anything that one considers innovative, I don't think it would be demonstrably better as of 2015 than the protocol that we're proposing. It's something you may say is a great idea, but certainly nothing has been validated in any kind of multi-center setting yet as being better than this protocol. If it had been, we'd use that. On the other hand, what Ben said is exactly right. You need to start from somewhere. And by standardizing the basic acquisition, you can actually create some benchmarks against which any innovation that comes across later can truly be measured. And so you know the amount of innovation or amount of advantage you really get out of your innovation. And I think that's going to be key.
Thank you, Dr. Barboriak. Here's a more particular question to any panelist. What do you think of acquiring a coronal spin echo T1 weighted sequence just after contrast administration that could allow interpreting vascular artifacts or other artifacts that could occur on the 3D T1 post-contrast reformatted images, particularly when they were acquired in sagittal.
I guess that's a very good point. I mean, it can be done. So what we did is just a minimum consensus. And like Ben said in his talk, sequences can be added. In particular, you can add T1 weighted after contrast to have some more information about contrast uptake or to eliminate artifacts, but that's up to you. That's just, you know, a very basic protocol, which can be, of course, supplemented.
And I would agree with that, with what Martin just said. That I think when you try to consider using this as a clinical protocol, many of the neuroradiologists you talk to will want another kind of T1 weighted acquisition, and that's completely fair. The impact on individual patients of calling enhancement where perhaps there's not real enhancement can be really profound. So for many neuroradiologists, having any possible area of enhancement confirmed in either another scan plane or just by using a different technique is really an attractive idea. And certainly in the way we've adopted this protocol clinically at Duke, we do that. We actually do axial spin echoes afterwards. And again, this just basically is in a sense, a sanity check, so that if you see anything that looks, for example, like a new area of enhancement that wasn't there before, and you wonder if it could be an artifact, just getting that extra security that's you've seen it again to at least some extent on perhaps thicker slices, but using a different technique helps your diagnostic confidence. And so for clinical use, I think that's really an important thing to think about at your individual sites. For research purposes, if we're doing these measurements that we want to automate, you know, I don't see that we necessarily have to adopt a particular solution to that. But I think for clinical use, there are different considerations you need to think about.
Thank you, Dr. Barboriak. Just on that issue of potential application of this protocol to clinical care, a viewer asked the question of this protocol is now being implemented in trials where there's no reimbursement for research imaging, and it is expected to be performed as part of a standard clinical procedure, or I guess could be expected depending on how you want to apply it. But the point here is, by the viewer, it says this creates, or I guess could create, financial and regulatory challenges in billing for sequences or additional time on the scanner that is not considered standard of care. Are there initiatives to propose this protocol as standard of care and address the reimbursement issues? I can say we haven't gotten that far yet with this initiative, but appreciate our panelists weighing in on that question of, again, ultimately use for standard of care and how it would affect payment.
It was actually our goal to have it very close to clinical practice and not to add examination time, but rather only to standardize. And I can only report from the ERTC trials, which are completely not reimbursed, that there's a very high adherence to the protocol because it's, you know, people accept it because it's very close to what they do clinically anyway. And so now it's just standardized. So I guess that's probably the best answer. It is accepted as non-reimbursed MR protocol in running trials in Europe.
Thank you, Dr. Benzius. Dr. Barboriak, do you mind commenting on sort of the future of this in terms of?
Sure, I think that the questioner raises a really important point, and I think it's the kind of protocol that I think was important to design as being acceptable as standard of care, and certainly at Duke that it has been accepted as standard as part of standard of care. So the way we do it is by adding a couple of pulse sequences that make it so. It does affect your reimbursement. I mean, the real effect you have is if you are doing it as clinical standard of care, you can actually make these trials happen in a less expensive way, because then generally when a patient comes on trial, if you have a particular protocol you demand to have happen, you might have to pay for that. On the other hand, if you're just routinely getting that as clinical standard of care, that really helps the trials. And the trials are really what help innovation. It's not only, you know, it's helped keeping radiology in the game. It's also helping develop these treatments that David is talking about that really help our patients. So I think, you know, decreasing the price of these trials and making sure that they're reimbursable is very important.
Thank you, Doctor. Another viewer asked a question. We are implementing these guidelines in several forthcoming clinical trials in glioblastoma. Is there a particular guidance or note of caution with this implementation that we should be cautious on when training the clinical sites on the use of the imaging parameters? Ben?
Yeah, so we've run into a couple of issues with some of the sort of other scanner types like Philips, Hitachi, in which they define some of the sequence parameters a little bit differently or don't put the sequences in the same DICOM fields as Siemens or GE. And so we've had to kind of work with the individual sites and with the imaging centers in order to get acceptable images on those types of scanners. So, you know, as more information comes in, hopefully we'll be getting more protocols from various sites that are using different types of scanners, different types of software, etc. And we'll be able to troubleshoot those type of things. But in general, I would say that about 80% of sites and centers that we've tried to do this in, it's been relatively easy to implement.
Okay. Thank you, Dr. Anderson. At this time, I'd like to turn to Dr. Dan Barboriak from Akron to make some remarks before we move into closing comment. Dr. Barboriak?
Thank you. Hopefully folks can see the slides. I want to thank you for the opportunity for being on this call. I really think that this brain tumor imaging protocol is really opening up new opportunities for us and future prospects. And I want to thank you all for taking time out of your busy days to attend. I also want to thank you for all the great questions that you've asked. These are the usual positions and disclosures. I have too many hats, so if anybody can remove some, that's great. I think one of the questioners sort of came up with this, with this same kind of idea, is that what we really need is standardization of advanced imaging, because the problems of pseudo progression and pseudo response as well are basically indictments of contrast enhancement as something to use as a marker for prognosis. And aren't we just getting better measurements of contrast enhancement, which we already know don't work incredibly great? And there's some truth to that. There's a couple things that really this brings us that are new, which is that if you just look at it without thinking about too much, it gives us a new understanding of contrast enhancement brain tumor imaging. And you might say, well, this is just simply a replacement for spin echo, so the slices are thinner, and so the gaps are smaller. This is not that big a deal. It does become a big deal when you think about defining contrast enhancement, because it turns out that our conventional way of looking at this, at contrast enhancement, was not always sensitive or even specific for real enhancement. In other words, sometimes you would call something enhancement that was actually intrinsic bright T1. This would be particularly an issue with metastatic disease, but also an issue with glioblastomas as well. They calcify and can be bright on T1 before you give contrast. So it's not particularly specific when you just measure bright things on a T1 weighted images after contrast. Interestingly, it's not even always sensitive. Sometimes you'll get a tumor that's dark on T1 weighted images before you give contrast, and then when you give the contrast, it just gets to the level of the adjacent white matter, and the edges can completely disappear. So I think this really gives us a chance of really measuring it for real. So we already talked about the advantages: spatial resolution, maybe better sensitivity and specificity. The other thing that I think is really advantageous is that this is something that's going to be useful not only for high-grade glioma, but it's maybe helpful in low-grade glioma. It has some applications in metastatic disease. It's something we proposed in trials of melanoma, for example, and even meningioma ought to be something that's very useful. And that sort of reinforces the idea that this could be a great clinical protocol to use as well, and that's the way we do use it at Duke. the real advantage to me as somebody who runs clinical trials is it starts to address some of the inefficiencies the readers does. What we do is we end up getting post-contrast images. We have readers take a look at it. Any two neuroradiologists get together, they disagree. And it takes a long time for them to even get around to looking at the images. The neuroradiologists tend to be expensive. And I don't mind expensive if they do a great job, but if expensive with a lot of disagreement doesn't make a lot of sense. And now when we treat tumors with anti-angiogenics such as bevacizumab, the edges of the enhancement can get a little bit harder to delineate, and it makes the delineation of the enhancement even harder. This protocol is really important for advanced imaging, and this is really the major point I want to leave with you. Segmentation is really an important step in image analysis processes for multiple advanced imaging techniques, whether it's diffusion, perfusion, what have you, even spectroscopy. And you may ask yourself, how important is it to get agreement in segmentation if you want to get reproducible advanced imaging technique results such as DCMRI? And I just want to show you something we presented at RSNA last year that came out of the Akron group from the RTOG 0625 study. But basically, I want to just show you a couple of examples to show how it works. Here is a case where there's some enhancement there. We registered the SPGR to the maps, and we just looked at what the answers were. And we had two different readers. And if you have two readers, and the reader A gives you a segmentation like this, reader B gives you a segmentation is what you see on the right, they're very much alike. This is the only difference I can see, so they're very close together. There's minimal changes. There's only 6% change in the volume of enhancement when you compared one reader to another in this case. And when there's only a 6% change in the differences, there is only a 3% change in the median K-trans, and there I've just superimposed the map. So there you go. When you agree on the volume, you agree on the actual result of the advanced imaging. Here's a different case. Patients had bevacizumab, and now you have something here on the left parietal occipital area where you see some vague enhancement. And how do your readers really react to this situation? Well, as you can expect, reader A said something like this, reader B said something like this, and I even today can't tell you who was right and who was wrong on this. But there was a substantial variation of segmentations, 140% difference in those volumes if you look at just the volume of enhancement. And unfortunately, if you have 140% difference in the volumes, you have huge differences in the median K-trans, 52% median differences in this patient. So that just sort of tells you in a nutshell, we need to get better segmentation to get better advanced imaging. It's a really critical step. In fact, if you look at a bunch of different things we looked at, whether you're looking at the model we use, do we use a simple model, something more complicated? Do we look at really terrible looking scans versus good ones? Do we look at different field strengths? The thing that was most predictive is that if the readers didn't agree on the volume of enhancement, they didn't agree on the metrics going across here. It's the number one thing. So this to me means that this is the number one thing we can do to reduce our variability in these advanced techniques. So when we have these new techniques, we can now build software to take advantage of this. Just to give you an example, here's a sagittal acquisition. Here's the pre on the left, post in the middle, and you just use a subtraction very similar to what Ben showed you. And it shows you the issues. You have things that are bright on the pre that turn out not to be enhancement, and things that you may say, well, I'm not sure this is enhancement in this lower corner, inferior corner, and it turns out it looks like, at least by computerized analysis, is enhancement. Now, it's not specific. A lot of things enhance, vessels enhance, dura enhances, but at least it gets you a better handle on what real enhancement is. So we got some challenges ahead. As the questioner said, we have to change our standards as the technology advances, and we want to make sure we don't close the door to innovation. These are going to be continual challenges that we'll just have to face and meet as we learn new things about segmenting areas of enhancement. And I think that, again, having a standardization, a baseline from which we can measure innovation, is probably one of the best ways to encourage innovation. We use it at ECOG Akron. It's our preferred clinical trials protocol. Now, it doesn't mean we'll never look at a different protocol, but there's the presumption of guilt if you're asking for a different protocol. You got to say, well, why exactly do you want a different protocol? And so it's being used in trials and development in GBM in particular, and melanoma metastases at ECOG Akron. And at Duke, we use it for trials, but we've also used it clinically since March of 2015. We use it for glioma, These are meds for meningioma. We happen to add a sagittal T2 as the first sequence. It's a great sequence. If you like it, if you don't like it, don't use it. And then we form a spin echo T1 after contrast spin echo with no gaps. We use some thick sections in the post-op situation so our neurosurgeons don't have to look through so many images. And really, neuro-oncology and neurosurgery are very supportive at my institution. Neuroradiologists, very conservative, maybe somewhat less so. And right now, the pediatric neuro-oncologists have an old protocol, and I hope to, by showing them the advantages of the new adult protocol, we may switch that over soon as well. So I really think that we will look back on this as a key step of moving forward in our imaging trials and imaging practice. And I really want to say a lot of thanks to Ben Ellingson for heading this up. People that have helped me, Jerry Boxerman, of course, David and Ann from the NBTS have been great. And if there are any questions, please email them to me. But I thank you for participating in this.
Issue, so we're fixing that. Okay, now I was told I can go ahead. Again, Dr. Barboriak, thank you. And in closing this webinar, on behalf of the Jumpstarting Brain Tumor Coalition, we want a big thank you to our presenters today and all of you who participated in today's webinar. I especially want to thank and acknowledge again the dedication of the members of the Brain Tumor Imaging Standardization Steering Committee who have worked together to make this possible. There are others very important to thank as part of this overall effort. The FDA for its important participation and support for our efforts to achieve standardization. The National Cancer Institute as part of the NIH for its valuable insights and participation. All of those who have already adopted the standardized protocol in the US and the EU, including companies and clinical trial groups and contract research organizations that have been helping them. Those professional societies and groups have helped to announce this webinar, and we thank you. In closing, we went into this effort all too aware that there are very few treatment opportunities for patients with brain tumors. Yet we are in an exciting time when the brain tumor clinical research field has many ongoing planned trial opportunities that will need to utilize imaging biomarkers and surrogate endpoints as part of their measurement of efficacy. We must maximize this rich and promising clinical trials environment for patients by working together, including the patient community, research community, industry, and government to improve clinical trial endpoints. We can in turn improve the landscape and opportunities for treatments to be evaluated and ultimately approved and brought to patients. As we now embark on the implementation to achieve field-wide clinical trial use of the protocol, the Jumpstarting Brain Tumor Drug Development Coalition is requesting the incorporation of the protocol as the standard for use in all future brain tumor clinical trials, both adult and in pediatrics. This represents an important step forward towards increasing the reliability of radiographic endpoints in brain tumor clinical trials and improving the ability to assess the impact of therapies in neuro-oncology. As you know all too well, we have to maximize this exciting era of where we are today with oncology research, particularly in brain tumors. Never has the field been more exciting and more rich with opportunities to make a difference. We have to seize this era, and by working very hard to improve neuroimaging and standardizing collection of data, we can seize this era. We again thank you for your attention and consideration of this new imaging protocol and for your participation today. We look forward to working with all of you to make things even better and to create even more and new opportunities for patients to live longer and live better. Thank you.